We are live now, doctor.
Okay. And I hope my screen is visible as well.
Yes, yes.
Oh,
Yes, Ritu, you can go ahead.
okay, sir. Well, it's somehow stuck in the first slide. I'll reshare again. Yes. Is it moving, sir? Yeah, all
Yeah.
right. So, yes. So, I welcome everyone here to yet another episode of our YOSI Journal Club, this time episode 14, and that's glaucoma themed. The title to it is Battle of Bypasses because we are discussing an amazing MSR study trial comparing two stents here. We have the presenter of this month, Dr. Amrita, and monthly mentor, Dr. Varsha, with us. Also, we have a keynote speaker on how to select right tools in glaucoma diagnosis by none other than Dr. Meena Menon. I thank our dear panelist members, Dr. Rita ma'am, Dr. Julie ma'am, and Dr. Archie ma'am to make some time here for a lovely discussion that we're going to have ahead. So, just a second. Okay. Yeah. The journal club was started way ago with the thought that publish or perish is the call to action. And therefore, our team YOSI 2024-26 with the governing council and the brainheads of executive members began this new journal club concept, which was to learn and grow together. It involves the participation of a resident team, the fellows, and also young ophthalmologists that we define as less than 40 years of age. So here we are, the team basically trying to assess all the research literature and beginning to involve more of residents and fellows. The format of our journal club is as such, we have one presenter every month and a monthly mentor who tries to make all the doubts clear for the mentee. The moderator of this session is me, Dr. Ritu, and we have one research expert along with panelists who welcome with positive comments, negative comments, and statistical critique. One unique idea that was given by the OG JC Club members was the Murray format, which Dr. Varsha and Dr. Amrita both shall be talking in further slides. Our team is comprising of Dr. Prasanna Venkateshwar sir, who is currently in Hong Kong, I believe, or traveling, so he couldn't join. We have the Dr. Sonal ma'am, Dr. Niranjan sir, Dr. Anujit sir, Dr. Ayushi ma'am, and Dr. Shreya and Dr. Ritu, myself. We are the two new members who have joined the YOSI Club just maybe 2 months ago, and we are really happy to join this. YOSI Journal Club has many themes, and starting from glaucoma and pediatric ophthalmology, moving on to oculoplasty, cornea, and cataract as well. Last year, we could also fetch nearly 10 sessions, and over 2 years, we have also the involvement of IGO, YOSI, Livewire, and the biostats as well. This is a webinars, and this is the 14th one. And we started off this year with cornea, which was moderated by Dr. Shreya. And now it's our second theme, that is glaucoma, battle of bypasses. Without taking much time, I'll welcome Dr. Amrita here, who is the presenter. She is currently a glaucoma fellow at Prabha Eye Clinic and had done her MBBS in Venkateshwar Medical College, Puducherry, and her master's in ophthalmology from Vellamal Medical College, Madurai. Yes, so Dr. Amrita, you can share your screen.
Dr. Ritu,
Yes,
sorry
sir.
to interrupt. Can we introduce the monthly mentor as well
Sure,
before?
sir.
Yeah,
I was just thinking we should save some time. Yes. All right. So
very good evening to everybody. Thank you, Dr. Ritu, for introducing our YOSI Journal Club and what we've been doing for the past few months. So, warm welcome to our panelists and our keynote speaker, Meena ma'am. And it's my privilege to introduce the monthly mentor for today, Dr. Varsha Velamdi. So Dr. Varsha has been a very active member in YOSI, and she's done her DOMS from MS Ramaya and is faculty and academic in charge at ESIC Gulbarga. She's done her secondary DNB from Arvind, fellowship in glaucoma, and has several accolades of FAICO in glaucoma and cataract and phaco. So currently working as a glaucoma and cataract consultant at Vasan Eye Care, Bangalore. So welcome, Dr. Varsha. Glad to have you on board. Next slide, Dr. Ritu.
Thank you.
So we have with us a star-studded panelist, starting with Dr. Julie Pegu. So she is a senior consultant glaucoma and cataract services at Shroff's Charity Eye Hospital and clinical adjunct professor in University of Wisconsin cataract training program in charge and mentor medical officer program. And she has several publications and awards to her name. She's passionate towards teaching and eradicating blindness from glaucoma. Next up, we have Dr. Rita Damankar. She is currently heading the glaucoma unit at Lakshmi Eye Institute, Panvel, and is the principal of Lakshmi College of Optometry. Ma'am has done her fellowship in glaucoma from the famous Bascom Palmer Eye Institute, USA, and she has specialized training, having trained under some stalwarts like Dr. G. Chandrasekhar from LVPI and Dr. Ravi Thomas at CMC Vellore. So she's one of the first ophthalmologists in India to start using SLT, and she is an active member of several associations and won several accolades, including Dr. Dastur's gold medal. And finally, we have our very own executive YOSI member, Dr. Harshi Singh ma'am. So she's currently the assistant professor at GNEC, Maulana Azad, Delhi, and she's completed her MBBS from the prestigious AIMS Institute, DNB Hostel from LVPI, and FICO and FAICO. And she is the section in charge of DOS Times and a very active executive member of YOSI and YOSI Glaucoma Forum Focus Group, and also the managing editor of YOTime. We are very, very privileged to welcome each and every one of you as the panelists. Dr. Ritu, I think we can go over to the speaker, and then before the keynote, we can introduce Meena.
Yes, definitely, sir. Thank you, Dr. Niranjan, sir. Dr. Amrita, yes, you can share your screen now.
I think we need to shops.
Yes,
Yeah,
sir.
perfect.
Your screen is visible. Yes. Go ahead.
Good evening, respected moderators and colleagues. I'm glad to be part of this, and I would like to extend my thanks to YOSI for this opportunity. Today, I will be presenting a 6-month outcome from the integrity study, which is a prospective randomized head-to-head comparison of iStent Infinite versus Hydrus Microstent as a standalone procedure in open-angle glaucoma. And this is one of the first trials comparing current generation trabecular stents in a rigorously washed out unmedicated population. This is published in Journal Ophthalmology in 2025. Journal has published conflicts of interest with Glaukos Corporation. We all know glaucoma is a irreversible disease, which is characteristic cupping of the optic disc with corresponding visual field defects. Open angle glaucoma is with a normal anterior chamber angle with elevated intraocular pressure. And we all know that the IOP is the most important and only modifiable risk factor for glaucoma. And traditional management includes the IOP lowering drugs often associated with the ocular surface disorders, decreased quality of life, and non-compliance. To minimize the tissue damage and burden of topical medication, selective laser trabeculoplasty, minimally invasive glaucoma surgeries, and procedural pharmaceuticals has been advanced to lower the IOPs. In mix commercially available trabecular stenting designed to lower IOP by enhancing conventional aqueous outflow include mixed devices with iStent trabecular micro bypass family of devices and Hydrus microstents, and these aim to bridge between the topical medications and the traditional filtering surgeries. And since 2004, the iStent has been introduced with the first generation iStent and the iStent Inject and iStent Inject W with 2 stents, and now the iStent Infinite, which has 3 titanium loaded stents. Current objective of the study is to conduct a prospective randomized multi-center head-to-head comparison between the effectiveness and safety outcomes of the current technologies which are administered as a standalone procedures. And this analysis reports on 6-month safety and effectiveness of interim analysis for the ongoing 24-month trial. Coming to the study design, this was a prospective parallel group 2-arm double mask study done over 4 countries in 7 clinical centers with 13 ophthalmologists who were trained in mix with prospective informed consent obtained from all participants. Coming to the inclusion criteria, study included adults with 35 to 85 years of age with open angle glaucoma, pseudoexfoliated glaucoma, and pigmentary glaucomas. At the baseline screening IOP, it should be less than or equal to 24 mmHg, whereas mean diurnal IOP after medication washout is 21 mmHg and 36 in between 36 and 21 and 36 mmHg with open angles on gonioscopy and corrected visual acuity 20/80. Exclusion criteria, secondary open angle glaucomas like uveitic neovascular glaucomas and patients with peripheral anterior synechias of more than 6 clock hours and any other chronic ocular inflammatory diseases or presence of active ocular inflammation or infections and any other cataract surgery or peripheral laser iridotomy or selective laser trabeculoplasties within 90 days prior to screening. All those subjects were excluded. Coming to the study devices, iStent Infinite. It is the current product that contains 3 preloaded intraocular stents manufactured from the implant grade titanium. This is about 360 microns in diameter with an outlet lumen of 80 microns, and these stents are implanted approximately 2 clock hours from each other in the trabecular mesh, thereby occupying approximately 3% of the angle and 97% of angle tissue is untouched. Whereas Hydrus microstent is a crescent-shaped implantable stent cut from nitinol tubing and preloaded into a handheld delivery system. Its overall length is about 8 mm and it approximately covers 3 clock hours of Schlemm's canal with the proximal portion of the implant exiting the canal through the trabecular meshwork. In coming to the overall length, it is about 360 microns with iStent and 8000 microns with Hydrus, whereas the length residing in the anterior chamber is estimated to be 105 microns with iStent and 1000 microns with Hydrus. At the baseline, informed consent has been taken and demographic data is collected along with medical, ocular, and concomitant medication histories. And in addition, women of childbearing potential underwent a pregnancy test. In coming to the preliminary examination, corrected visual acuity by Snellen's, perimetry, slit lamp biomicroscopy, Goldman tonometry with a and gonioscopy, pachymetry, and dilated ophthalmoscopy has been done. A key strength in this study is medication washout before the 6-month assessment, allowing measurement of true unmedicated IOP. And this drug washout time is different for each drug. Carbonic anhydrase inhibitors and myotics for 5 days, and alpha agonists it is 2 weeks, and beta blockers, PG analogs, and rho kinase inhibitors it is about 4 weeks. Once drug washout time is completed, occurrence of any adverse events was noted, manifest diffraction was done, best spectacle corrected visual acuity is done, and IOP is measured at 8 a.m., 12 p.m., and 4 p.m. And at this visit, unmedicated mean diurnal IOP was required to be in between 21 mmHg and 36 mmHg. Coming to the randomization of the subject, selected candidate, if one eye is selected, the patient will be randomized. If 2 eyes are qualified, based on the lens status, if the patient is having different lens status, that is one eye is phakic and another eye is pseudophakic, only one eye is randomized and it is chosen by the investigator. Whereas if there are same lens status, then the worst of the 2 eyes is randomized. If the 2 eyes are equivalent, then left eye is to be randomized first with either iStent or Hydrus, and the contralateral eye will undergo the opposite procedure the following day or later. After baseline visit, the eligible subjects were scheduled for surgery and instructed to follow a preoperative regimen, and surgery was performed according to the manufacturer's instruction. Postoperatively, topical antibiotic and topical non-steroidal anti-inflammatory drugs were given. In order to obtain unmedicated IOP at month 6, eyes on the IOP lowering medication, which are restarted after the implantation at month 5, they have been initiated a washout prior to month 6, and with those eyes which are not on any IOP lowering medication at month 5 return for an unmedicated mean diurnal IOP measurement at month 6. At each visit following implantation, intraocular pressure measurement was done. At month 6, it is diurnal IOP measurement, whereas over POD 1, week 1, months 1, 3, and 5, single time point IOP was been taken, and visual acuity, gonioscopy, ophthalmoscopy, pachymetry, and perimetry were done, whereas slit lamp biomicroscopy and adverse event measurements were done in all visits. Investigators has used this clinical judgment on case-to-case basis whether to reintroduce the medications. If at all, if it is needed, the same class of medication has been introduced post-implantation. Coming to the effectiveness and outcomes measured at month 6, effective analysis is measured as observed case analysis, where the proportion of eyes that achieve the mean diurnal IOP reduction from baseline of more than or equal to 20% reduction, regardless of either IOP lowering medication usage or surgical complication. Whereas pre-specified primary effective analysis, it measured unmedicated MD IOP reduction from baseline without surgical complications. Whereas additional effective outcome analysis, proportion of eyes achieving less than or equal to 17 mmHg regarding of lowering medication or surgical complication are assessed, whereas secondary effectiveness outcome analyzed changes from the baseline in the MD IOP at month 6 without any target IOP. Coming to the statistical analysis, they aim to detect 25% difference between the two treatment groups, unmedicated MD IOP reduction from baseline of more than or equal to 20% at 12 months, whereas effective analysis was performed using intent to treat analysis set, whereas safety outcomes were performed using the safety analysis set, and continuous measures and categorical measures were measured by two sample t-test and Pearson chi-square test and Fisher's exact test, whereas statistical analysis were performed using statistical analysis software version. Coming to the results disposition, a total of 144 eyes were screened. In that, 37 failed screening. Out of other 104 eyes, 18 has undergone eye stent implantation, whereas 16 has undergone hydrous, whereas 73 eyes have undergone eye stent and hydrous implantation. At the beginning of the study, a total of 91 eye stent and 89 hydrous eyes were there. By the end of 6 months, one subject with eye stent in one eye and hydrous with another eye has withdrawn, whereas 2 eyes with eye stent and 2 with hydrous were withdrawn. So at the end of 6 months, a total of 88 eye stent eyes and 87 hydrous eyes were available at the end of 6 months, which is very good follow-up, about 96%. Coming to the demographic and preoperative characteristics, the mean age group for the eye stent infinite is about 63 years, whereas in hydrous it is similar, 62.9, whereas females are similar in both groups. And coming to race, it is more racial ethnicity, it is more of whites, and it is about 90 in eye stents and 87 in hydrous, whereas only one black or African population is included in hydrous. Coming to intraoperative results, 90 out of 91 eye stent eyes were implanted with eye stent infinite with 3 stents in each, whereas one eye, the third implant has gone below the scleral spur and improper anatomical placement was there, and so fourth stent has been implanted. And in the same eye, there was an anterior capsule damage which led to cataract, which has been the eye has undergone cataract surgery the next day, and there is formation of peripheral anterior synechia, which is more than 1 mm at the end of 6th month in the same eye. Whereas coming to hydrous, failure to implant the hydrous stent is seen in one eye, despite after 3 attempts, and in the same eye, iris prolapse has been seen with intraoperative iridotomy done, whereas in the same eye, after 5 days, peripheral anterior synechia is seen and dyschorrhea is seen 3 weeks after the surgery. In one pseudophakic eye with hydrous implant, vitreous prolapse is noted, and in 7 more eyes there is a improper anatomical placement where in one eye iridodialysis is seen and the stent is in suprachoroidal space, and postoperatively peripheral anterior synechia is seen, whereas in 3 eyes with hydrous implant, portion of stent is seen in suprachoroidal space. Whereas in one eye, distal tip is posterior to Schlemm's canal and anterior tip into anterior chamber than the ideal position. And in one eye, distal end is protruding into the anterior chamber. In another eye, distal end is contacting the iris. Coming to the primary effectiveness outcome at month 6, the based on observed case analysis, 82.7% of eyes in iStent Infinite has reduced mean diurnal IOP when compared to hydrous stent without any, including surgical complications and the medicated IOP. Whereas in primary effective analysis, the iStent Infinite has 78.2% proportion of eyes with reduced IOP, whereas Hydrus is having only 65%, and this 13.2% treatment effect was statistically significant, showing superiority of iStent Infinite over the Hydrus. Coming to the secondary effectiveness outcome at month 6, the proportion of eyes less than 17 mmHg in iStent Infinite group during the observed case analysis is 65.8%, whereas in Hydrus stent it is 64.2%, whereas in primary effective analysis where there is unmedicated MDIOP with the surgical complications, uh, without surgical complications, the iStent Infinite is giving about 62.62%, whereas Hydrus is 51.7%, which is statistically significant again. Coming to the mean IOP, in observed case analysis, it is about 7.4 mmHg reduction, whereas it is 7.2 mmHg reduction in Hydrus group. Whereas in primary effective analysis, it is minus 6.8 mmHg, whereas in Hydrus, it is minus 5.7 mmHg. This minus 1 mmHg difference was statistically significant and superior in the iStent Infinite group versus the Hydrus group. A 95% confidence interval is at minus 2 mmHg to minus 0.2 mmHg. Unmedicated MDIOP of less than 21 mmHg was statistically greater in the iStent Infinite group compared to the Hydrus group, whereas less than 15 mmHg and less than 18 mmHg are not statistically significant. Whereas the proportion of eyes with more than or equal to 20% reduction was statistically significant greater in the iStent group compared to the Hydrus group.
Amrita, is all good?
I'm sorry.
Amrita.
At month 6, the mean number of IOP lowering medications in both the eyes is similar, and as the only 3 eyes in each group has required IOP lowering medication. Coming to the adverse events, failure to implant stent is seen in one eye in Hydrus group, whereas improper anatomical placement is seen in 7 eyes in the Hydrus group. Peripheral anti-synechiae is noted in 9 eyes in the Hydrus group, whereas it is noted only in 4 eyes with the iStent. If we see peripheral anti-synechiae more than 1 mm, it is seen in 4 eyes in the Hydrus group. And significant ifema is noted with the 4 eyes in the Hydrus group, where it is only 1 eye in the iStent group. And vitreous prolapse is seen due to significant capsular tear in 1 eye in the Hydrus group. This study evaluated the 6-month safety and effectiveness of the two trabecular stents, iStent Infinite and Hydrus microstent. In both groups showed similar results in observed case analysis, which achieved mean diurnal intraocular pressure reductions of over 7 mmHg and maintaining pressures below 17 mmHg. The predefined primary endpoint, which counted eyes with surgical complications or those requiring medication as failures, iStent Infinite was statistically superior to Hydrus. Coming to unmedicated pressure, iStent Infinite achieved a significantly greater reduction in unmedicated mean diurnal IOP compared to Hydrus. Both technologies successfully reduced the need for topical medication, with the mean number of medications dropping to near zero by month 6. Complication rates. Hydrus group had a significantly higher rate of surgical complication compared to the iStent group. This difference may stem from the substantial size difference between the microinvasive stent, iStent, and the large Hydrus device. Hydrus eyes experience more frequent improper anatomical placement and peripheral anti-synechiae compared to iStent eyes. Complications were included as failures because malposition devices or tissue damages can lead to long-term inflammation and further injury, which is a critical concern in the early stage glaucoma patients. Comparison with the existing research, the COMPARE study Unlike the previous compare study, it has used old first generation iStent technology with the hydrous, whereas this integrity study used current fourth generation iStent, which has 3 stents in it. The study addressed previous research limitations by successfully implementing a rigorous medication washout for over 96% of the participants. Coming to limitations, the current analysis is limited to 6 months of follow-up and lacks significant spatial diversity. There was no strictly defined algorithm for reintroducing the medications, though this was mitigated by the mandatory washout period before 6-month assessment. Coming to MARI protocol, coming to methods, study design, it is a prospective two-arm study done in 7 centers across 4 countries. Inclusion criteria and exclusion criteria are well defined. Assignment, all cases randomized and assigned to 13 experienced mixed surgeons. Assessment, outcome measures were well defined and analyzed. Subjects and IOP assessors were masked. Results, statistical analysis were done with standard methods. Extrapolation, it can be generalized to mild to moderate open angle glaucoma patients, but 1.1 mm difference in mean IOP between 2 groups is not clinically significant, and it needs 24-month assessment for tracking the efficacy and safety outcomes. Thank you.
Thank you so much, Dr. Amrita. That was an excellent overview, I must say, and what a comprehensive study it must have been for you to prepare.
Yeah.
Good job.
Amrita did a very well job. I mean, it was such an exhaustive article for me also to go through, and so
Yes.
many statistical points were there. I think it is a very well statistically conducted study. I mean, the analysis is very good. I mean, to all the residents who are attending, I think they would not know what does a two-sided alpha mean. I think I'd like to explain that. So basically, it means alpha is the probability of making a type 1 error, that is a false positive. And what do we mean by two-sided alpha is when it considers both the upper tail and the lower tail of the false positiveness. That is one thing which I'd like to add. And yes, the study is mainly sponsored by Glaucos. That is one thing we should keep in mind. And if you see, if we want to summarize at the end, it's a 6-month study, which is it's a randomized control study, which is the double masked. It is very statistically very good. But in the end, if we see the difference between the each, intraocular pressure reduction is only 1.1%. It may be statistically significant in their sample size, but if we apply it clinically, then it is not that significant. This is what we have to say. And then coming to the practical measures in India, are we able to implant these? One thing is, the cost of both is around $1,400 to $1,900, which comes to around a lakh or more than that in India. That is one thing which you have to consider. And the feasibility of implanting in iStent Infinite, relatively easier. What the wet labs have done, iStent is relatively easier compared to the hydrous. But then with hydrous, we have to remember that it occupies a larger area of the anterior chamber, and hyphema is the most common complication associated with it. And I think with this, I'd like to ask the other panelists to please tell their inputs. Thank you.
Thank you, Dr. Varsha, for the insightful help as well as your perspective on it. And while the other residents and fellow communities can think of questions, I'll welcome our panelists one by one for their inputs as well. Keeping in interest with time, I think Dr. Rita, you would like to go first with the positive comments on the presentation and the paper
I have a
itself.
small presentation which I can share. So, I
Yes, ma'am.
compared all the points, so it'll be easier for everyone to follow.
Wonderful, ma'am.
Yeah. Thank you very much for inviting me to this. Sorry. Give me a couple of minutes.
Definitely, ma'am. Dr. Amrita, you can take a sip of water now. The article exhausted you.
I'm sorry.
Yes,
Everything
ma'am.
is getting lost. Well,
No issues,
this
ma'am.
was a wonderful
Yeah.
presentation done by Amrita. She's really done a very nice study of the entire the implications of this whole infinite study. It was only a 6-month interim presentation that they have made at this point, but there are major strengths in this study. So, I'm sorry. I'm sorry, I'll just off my phone. Yeah. So I think that the first thing is that you have to know that the quality of the study design was very good because it was a prospective randomized multi-central trial and it had an access to several countries, and all of the surgeons who were doing this were very well trained to do this. So there was no learning curve whatsoever. Also, it was a double mask design, so there was no confounding factor happening over there, both in terms of the patients as well as in terms of the assessor. So the person who was measuring the intraocular pressure or doing all the other readings. It was a parallel group head-to-head comparison of two really newly used, because the integrity was used, it was a new trabecular stent that we are using. And this trial has been also registered, so there is a lot of transparency. The comparison, of course, she has told us, is almost very good in both the groups. There's it avoids the common limitation of comparing older stents with newer stents, and it is one of the very few randomized standalone mix versus mix trial. It's a very practical, relevant problem because presently these standalone procedures are not done as often as they are done together with cataract surgery. Here, therefore, because we are not doing a cataract surgery as a part of the surgical process, the reduction in intraocular pressure that can result because of the cataract surgery and the inflammation that can result because of the cataract surgery, both have been taken care of. I think the measurements for methodology of looking at the intraocular pressure was also quite robust because they looked at 4 readings for the diurnal variation, and they also had 2 readings taken successively. They didn't take just 1 reading and wait at that first reading when they were doing single measurements also. The best thing about this was that it had a very good medication washout, and the washout was done very thoroughly because it had different time lags for each medicine to be washed out, and they made sure that at baseline at least they had patients that they were including in the trial who were not on any medication, and all the other factors have already been explained here. The primary endpoint is also very well described, and I think that this is a very good real world and conservative approach because they're looking at surgical complications or patients on IOP lowering medications which were actually considered as failures. So they didn't come into the results of the study at all. And worst case imputation used for some secondary analysis, which strengthens the credibility of the results. I won't talk on the statistics because we have somebody, Julie is going to talk on the statistics. So I'll leave the statistics for her to look at. But I think it was a very good, very well sort of prepared statistical analysis for this entire thing. So the baseline I told you was matching. It was a large, well-conducted head-to-head mixed study where 180 eyes were finally enrolled in this study. So probably a large prospective randomized comparison. And both the devices, finally, if you look at the results, achieved strong clinically meaningful IOP lowering. There was a difference of 1.1 in the two, which was statistically significant. But if you look at practice, if you get, such a good fall in intraocular pressure, even with the medication washout at the end of 6 months, it means a lot to us. So if you look at the results, efficacy of the stents, I think both the stents did comparably well. iStent did better, but they did comparably well in the long run. However, this is just a 6-month study, so I think 6-month readings that we are looking at, and glaucoma being a lifelong disease, you have to wait until the 24-month trial is over, and you have to see what happens actually at the end of 24 months. Though, of course, 6 months is not a very short period, you would see failures even as early as this. but which have not come forth, which is looking like really, really nice. And the good thing was that there are pretty clinically relevant medication outcomes that we have seen, because the mean medication in both the groups was essentially 0 at the end of 6 months. So which means to say that, there was no way in which medications came in the way of looking at the results at all. I think the reporting was very good and transparent. We had a comprehensive reporting of everything that was mentioned, as Amrita mentioned to start with. And clinically, the visual outcomes were quite reassuring, because 96% of the eyes in both the groups had a best corrected visual acuity of greater than 20/40. And there was no meaningful loss of vision attributable to either device. I think also that it addresses the limitations of the previous comparative trials, where we are using the current devices, we are enforcing medication washout, we are pre-specifying the endpoints and analysis plans, and we are avoiding post-hoc changes to the primary outcome. If you look at it in terms of external validity for everyday glaucoma practice, I think, the one thing that we need to know is that it was nice that they took patients with primary open angle glaucoma, pseudoexfoliative glaucoma, pigmentary glaucoma, patients previously treated with glaucoma with SLT 90 days prior to them being admitted into it, and they were both phakic and pseudophakic patients. And this is, I think, the kind of patients that we see in real-time practice in glaucoma, because the early and the mid or moderate glaucomas do not necessarily have, come mostly present to us in this same state. So if price was not a big concern, that is the biggest limiting factor. We could actually take this into our own practice, this study into our own clinical practice, knowing fully well that you have to be very well trained in doing both these procedures. You cannot, otherwise there's bound to be a learning curve. There's bound to be more surgical complications. So having taken all of this into account, I think basically this was all the positivity that I saw in this study. Thank you very much.
Thank you so much, Dr. Rita, ma'am. I must say, I should appreciate rather that you broke down that evidence and linked it to the real world decision making also in the end. So yes, before we
And the
delve
other thing,
into,
I'm sorry, the other thing that I also forgot to say was that this was a standalone procedure. That means all MIGs are normally combined with cataract surgeries. Here we did a totally standalone procedure MIGs. Therefore, we know that cataract surgery did not interfere with the results at all.
definitely, yes, ma'am. Thank you so much, ma'am. And before we delve into statistics, I would call quickly Dr. Arshi, ma'am, to outweigh the negativity with what Dr. Rita just said. Maybe a funny rebuttal.
I
Yes,
would
ma'am.
actually thank you so much, Rita ma'am. You made my life much simpler because you already talked about the real world context, as Ritu just said. And overall, I think the study in general was conducted pretty well because they seem to have addressed most of their limitations. We do need to understand that the study is wholly funded by the device manufacturer, or at least one of them, and multiple authors or investigators have industry relationships with the very same industry point. So there might be a difference in the endpoint neutrality or in the way the results have been interpreted, especially the tone of writing. So we should probably take that with a little bit of a pinch of salt, because as we said, that considerable difference that they seem to find, while statistically relevant, might not translate into clinical practice for us. The other thing was, as they've already discussed, that they haven't mentioned about what sort of severity these patients actually were. So maybe if they could have classified according to the grades of severity, that would have made it a little more easy to take to clinic. And also there was limited racial diversity. We know that everything differs according to the region that you're in. And we should probably try these things in Indian eyes and see how it works for us. Also, they've already discussed that the medication reintroduction wasn't protocolized tightly, and that could be a source of potential bias. And the fact that they used the same subject with different eyes. So one eye was given hydrous, the other one was given eye stent, 1 week apart. And the post-op regimen I would want to comment on. Till now, whatever studies mostly we've seen have been using low-dose steroids, but they did not use any steroids at all, and they used NSAIDs in their post-op regimen. So that could be something that could have resulted in their safety outcomes being a little less with the post-op complications that they saw in the other groups. Thank you so much. That's all I have from my end, actually.
No, actually, you've done a good job, Arshi, because no, the way they've presented the paper, it's very, very positive. Though I know
Yes,
that we have to look at the negatives
because
as
the
well.
pure IOP lowering actually looks similar at 6 months.
At 6 months, that's
And
right.
they're actually, so if you look at their composite endpoint, that is what they're depending heavily on, that the safety parameters and the
Yes.
unmedicated IOP. But ultimately, take clinic is how much is the change of IOP. And that kind of remains the same. Plus, I think hydrous is something that has still, we're still discussing it a little more. People have now started using it in India. So we'll probably be seeing much more research work on it now.
Sure.
Ritu?
Ritu, you're muted.
Unmute yourself,
Yes,
Ritu.
yes.
Yeah.
I'm so sorry. Yeah, I was just thanking Dr. Arshi to add an important nuance to the discussion. Not
Thank you.
everything is a silver lining.
Can I also thank Amrita again for beautifully presenting this article? Her slides were excellent and she really presented well. And also a big round of applause for her mentor for having guided her through this very difficult article. Thank you.
Really, we have to, congratulate Amrita because she just had a family emergency. And in spite of that, she has presented. I think that itself shows how dedicated as a glaucoma fellow she is.
Congratulations and keep it up. We appreciate
I guess
the
she
efforts
can't
you
hear
take.
that, but yeah, she did have a medical emergency. She just texted me. All right. We can move further to having a statistical critique. And I welcome Dr. Julie Pegu ma'am for her insights.
Yeah, hi, good evening all. And really, Amrita did a brilliant job presenting the paper, such a complex one, but she made it sound very easy. And I also like to thank Varsha and Dr. Rita and Dr. Arshif for their beautiful explanation of the whole paper. So my statistical perspective on a trial would be like from a statistical standpoint, the study is methodologically robust, but its conclusions are highly analysis dependent. So the trial used eye level randomization with a substantial proportion of patients contributing both eyes. So one was randomized to the eye stent infinite group and the fellow eye was randomized to the hydrous group. Now this paired eye design improves efficiency and controls for patient level confounders, but it also violates the assumption of independence between observations. Appropriately, the authors addressed this by using generalized estimating equation, which is called a GEE, and which is probably the correct statistical approach to account for within subject correlation. Now, the use of GE prevents overestimation of significance, but strengthens the integral validity of the treatment comparisons. Now, when you come to the choice of the primary endpoint, so when ignoring complications, the effectiveness was found to be similar between the two groups, but the primary endpoint was a composite success that combined the more than 20% unmedicated mean diurnal IOP reduction.
Yes.
There has to be no surgical complications and there has to be no need for IOP lowering medications. Now, statistically, composite endpoints increase event rates and power, but they also shift interpretation away from the single biological effect. In this study, the composite endpoint blends efficacy and safety, which means that the reported superiority reflects overall procedural success. Like in this case, IOP reduction, both the IOP and the safety, like with no complications and not only IOP lowering ability. So if you focus on IOP lowering when implanted, both devices look comparable at 6 months. But the superiority emerges primarily because Hydros had more procedure related events, and that is classified as complications and failures. Like even if PAS of more than 1 millimeter was said to be a complication, like which was more in the Hydros group. And also the primary analysis used failure imputation, where eyes that reported required medications or experienced surgical complications were automatically counted as failures regardless of their measured IOP. So, so when one group has a higher complication rate, the imputation mechanically amplifies the differences. So in this study, the medication use was rare, like more than 96% of the washout success was present in both the groups. So the dominant driver of imputed failure was the surgical complication. And that is why the statistically significant 13.2% treatment effect was sensitive to how failure was defined and imputed, and not just to the efficacy or lowering of the intraocular pressure. So a major statistical strength of the paper is that the authors transparently reported both the observed case analysis, that is pure efficacy, that's only lowering of intraocular pressure with no imputation, and also they reported the imputed primary analysis, that is the composite success. And the authors appropriately reported the confidence intervals, which are far more informative here than the p-values alone.
Yes.
And statistically, this suggests the study may be underpowered for some secondary endpoints like a categorical threshold, like mean IOP of less than 17 millimeters of mercury. The baseline characteristics, including mean deviation and intraocular pressure, is exceptionally well balanced. And however, the population was predominantly mild glaucoma, so that may limit the statistical generalizability to the advanced disease. Again, we have to remember that this is a 6-month and interim analysis of a 24-month trial. And so this finding should be interpreted as early signals and not definitive long-term evidence. But again, what Rita ma'am and Dr. Arshi had said, that, at least it is a positive thing that they are doing well. In most of the patients, they have worked so well. Like if you take the cost out of it, I mean, Hydrus being a bigger implant definitely will have more learning curve. Like, a more like anatomically, like it is difficult maybe to place the stent, the hydrus into the right place. So I think once we can master that, how to place the implant, probably it's really going to be good in the near future. That's what our take is on. Thank you.
Thank you so much, Dr. Julie. I must say I should go back to reading the whole paper again to see these statistical points. Very well informative
Thank you.
perspective. And to our lovely over 20 participants, I would ask them really take this opportunity in your hand and throw your questions at the panelists, because we have amazing discussants here. And we can wait for a minute or two. If you have anything, you can write in the chat box, or I can move further with our keynote speaker. Take your time. So I'll be just sharing my screen. I hope it's visible. We have shy
Yeah,
audience
visible.
tonight. I'll welcome Dr. Meena Menon ma'am here, who is the keynote speaker today. Ma'am is currently serving as the senior consultant in the glaucoma unit at Shankara Eye Hospital, Bangalore, and she manages majorly adult and pediatric glaucomas. She has a variety of practice at various states that I can see at Bangalore, Hyderabad, Pune, and Madurai, Tamil Nadu, Karnataka, Maharashtra, and Andhra Pradesh. She has delivered many faculty talks and invited lectures at international and national fora, published book chapters, conducted drug trials and clinical studies, and is also a DNB coordinator and chairperson in the Hospital Infection Control Committee. She has various society memberships as well, and we are very much pleased to have you here for the speak of the evening. Over to you, Dr. Meena ma'am.
Thank you, Dr. Ritu, for that kind introduction. And after the stormy integrity study, I'm going to back to basics. So we're just going to discuss. Let me share my PPT. And it was really wonderful presentation by Dr. Amrita and discussions also. Is my 1 second. Is my slide visible?
Yes, ma'am. Perfect.
Yeah. So we're just going to back to basics. How do we decide on certain tools which can help us in diagnosing and even in the management of glaucoma? So as you all know, we have to do a thorough clinical evaluation, which includes the history taking, clinical examination, your IOP evaluation, gonioscopy. All this have to be integral part of your clinical evaluation. Now, I'm just going to touch upon certain key points in all these things. Uh, I'm not getting into the detail of the history or details of the examination. So be very proactive in screening the patients, especially the patients who have risk factors like older age groups when they have noted to have an elevated intraocular pressure, when there is some kind of optic nerve head changes which you are seeing, when the patients have confirmed family history or diabetes or hypertension. These are some of the patients who are at risk. So please make sure that you screen for glaucoma in your even in your general OPD when you are examining these patients. Some of the key ocular history which I want to highlight is understand whether the patient has undergone any kind of previous surgery. Nowadays, especially, it is important to understand whether the patient has undergone any kind of refractive surgeries, because now more and more patients are going to come back to us who have undergone various types of refractive surgeries, and of course understand the lens status. Again, have they undergone an ICL, post ICL, cataract removal. All these are becoming very common in our day-to-day practices. Coming to some of the medical history, all of you are aware of all the medical history which we should usually ask, including asthma, rheumatoid arthritis. I keep telling my students, like, many a time we don't look at the patients when they enter to our room. Look at the patient as a whole. Many a time we miss a slightly deformed, fingers, which might be pointing us towards a rheumatoid arthritis. When we prescribe an anti-glaucoma medication, beware or think of their dryness also. Of course, migraine as a part of normal tension glaucoma history, as well as part of the treatment also, and history of any cardiovascular heart block. These are not very commonly asked. That's why I wanted to highlight. Definitely all medical history, past medical history is important to understand. Of course, smoking, alcohol, and nowadays it is very, very crucial to ask for a sleep pattern, because more and more cases we are seeing with obstructive sleep apnea, and studies have proven that using a CPAP can halt the progression of patients with normal tension glaucoma. So ask for the sleep pattern, because many of the patients don't even know that this can be associated with glaucoma. Drug history, that some of these drugs definitely can affect your treatment, like aspirin, the steroid intake for any condition, systemic beta blockers. It can have an additive effect when you prescribe certain drugs. And of course, we should understand the important drug interactions also. Now, this is a classification which I've taken from one of the article, wherein which highlights the cardiovascular toxicity of the anti-glaucoma medications. So it's like n number of toxicity. So when the patients also tell you that I've had this problem, I think many a time we should go back to understand, is it because of the anti-glaucoma medication? So we sometimes belittle when the patient tells some of the systemic issues which they face, but understand there are innumerable complications which can happen even with the topical medications. And this is a commonly prescribed drug, carbonic anhydrase inhibitors. It's like worse than paracetamol sometimes being prescribed. So understand all these drug classes can have interactions with carbonic anhydrase inhibitors. So including your normal NSAIDs, diuretics, many of our older patients may be on diuretics. And of course, topiramate or barbiturates, if the patients are on, be very, very concerned about their metabolic acidosis or chances of getting kidney stones. And immunosuppressants, we should understand many patients are being given cyclosporin, even topical as well as the systemically. So systemically, it have shown there is an increased blood levels toxicity. Once we move from the history, a thorough anterior segment evaluation, which you can pick up umpteen findings like pseudo exfoliation, you can pick up an NVI, And of course, many a time we pick up a small sphincter test and then we go back and ask the history of trauma. So the patients many a time will not even remember that they've had a blunt trauma. So look for any kind of sphincter tear or change in pupillary size, and this kind of picture wherein there is a lot of multiple synechiae which is present. We have to go back and ask history of chronic redness, usage of steroids. All this becomes extremely important in your anterior segment evaluation. Of course, you will go ahead and do your intraocular pressure measurement. To tell you, Shiots have become almost obsolete. Try to have these kind of standard instruments to measure your intraocular pressure. It's worthwhile to spend on these instruments than using a Shiots tonometry. You can use an applanation, handheld applanation. Eye care does give a good IOP reading in normal corneas. In case there is any scarred or irregular corneas, you can use tonopen as well. Of course, gonioscopy, this is not a specialized investigation which we do. Every ophthalmologist should be able to do a good gonioscopy and get all the findings. Like it can be an open angle, closed angle, angle recession, as you see in this picture. So multiple findings we can get through only gonioscopy itself. So a thorough examination of all these findings are important. Now, I'm just going to little bit detail about the fundus evaluation. Dilated fundus examination is a must. Even if your patient scream at you, I'm waiting for 2 hours, it doesn't matter. Please make them understand the importance of dilated fundus evaluation. So as you all know, normal optic nerve head, whenever we evaluate, all these parameters have to be checked for the size, shape, cup disc ratio, neuroretinal rim, color, whether there is any evidence of thinning, peripapillary atrophy, of course, any vascular changes in the form of disc hemorrhages, whether the blood vessels are arising from the center of the disc or is there any nasalization, any evidence of nerve fiber layer defects, and of course, whether there is any bending of retinal vessels or any tortuosity or sclerosed vessel. All this becomes part of the fundus examination. When we talk about the morphology of normal optic nerve head, we can classify them into small, medium, and large. So you can use these scales to understand whether, understand whether it's a small, medium, or large. And of course, we have to use correction factor. So most of us use a 78D or 90D. So the correction factor, this is a commonly asked if any of the DNBs are attending. These are the commonly asked questions. What are the correction factors? So around 1 to 1.3 for 78D and 90D, 1.36 to 1.59, and understand whether the optic nerve head size is symmetrical in both the eyes. When we talk about the shape, usually the disc is vertically oval and cup is horizontally oval. So whether the disc and is torted or tilted, these are the two other important findings. Because many a time when the disc is tilted, we tend to miss the notching or the thinning of which is happening in the two poles. So please look very carefully, especially when the optic disc is tilted. When we talk about cup disc ratio, as you all know, like only 2% of the population has a CD ratio greater than 0.7. So anything like when you see beyond 0.5, look at the optic disc very carefully, whether there is any asymmetry between the eyes. And another important finding which I want to highlight here, it is not always the color of the cup. It is something called as contour cup. You understand whether there is any vessel bend which is seen, and that is what we have to see, which is seen in this blue arrow. Where there is a vessel bend, that is what we need to note as a contour cup. When we talk about the neuroretinal rim, whether it is following an ISINT rule is something which you have to look for, and see whether you are dealing with a myopic disc, whether you're dealing with a normal disc, because in a myopic disc, understanding a neuroretinal rim is very, very crucial. We have to know about zone beta and zone alpha. So zone beta, which is closer to the optic disc, which represents the retraction of the RPE, that is significant or more extensive in cases of primary open angle or a normal tension glaucomas, and other zone alpha is away from the optic disc, which is an irregular hyper or hypopigmentation, which may not be very significant in a case of glaucoma. Now, I'm just going to show some patterns of normal disc patterns. If you see the first picture, so if you see, this is a concentric cup, and if you see, there is a bend of the blood vessel and there is an early notching which is seen superiorly. These are various pictures of early notching inferiorly which is seen. And if you can see, this is a concentric thinning of the cup, and this is more of an advanced glaucoma wherein most of the rim is lost, almost 0.85 to 9.9 cupping is present in this picture. So the vascular changes, which can be seen in the form of splinter hemorrhage. So usually what is splinter hemorrhage? So basically it is located, any hemorrhage which is located 1 disc diameter from the optic disc is considered as splinter hemorrhage. Now, if you see, only 0.6 to 1.4% of the normal population can have a splinter hemorrhage, whereas if 1.9 to 16.9% of the subjects with glaucoma can have splinter hemorrhage. So usually they vanish by around 3 to 4 months. One more important thing, suppose if you have treated the patient and the patient is on anti-glaucoma medications, and one fine day patient comes back to your office with a disc hemorrhage, be very, very careful. It can be a sign of poor prognosis in glaucoma. Maybe the patient has been having a lot of fluctuations in the glaucoma treatment, or patient has not been regularly using the drops. So look at the disc very carefully at each visit for this finding. Of course, RNFL defect, Quigley always found out, described these RNFL as a very sensitive indicators of early optic disc changes. You have to use a red-free filter and see whether, look for any kind of RNFL defect which can be noted during a slit lamp examination itself. Now, once we do a thorough clinical evaluation, now we need to move in for the investigations. Now, what are the investigations? How do we go about it? So we can divide very arbitrarily into a new case and a follow-up case, and what are the other newer tools which we can play around with. So this is a patient who came for a routine checkup, who's a contact lens wearer, and her anterior segment was relatively normal, and the intraocular pressure in both the eyes was noted to be almost normal with 14 millimeter of mercury. This was a picture of her fundus, wherein one eye was relatively looking normal. It's almost 0.5, whereas the other eye showed a 0.7 with an early inferior notching to a little thinning, which is vertically oval cup. So when we see such kind of a patients, we can opt for an Humphrey field analysis. Of course, we have to get a pachymetry reading done. For her, it was relatively thinner corneas. Mind you, she has not undergone any kind of refractive procedures. So the Humphrey field analysis, we can ask for a CETA swab and a CETA standard, either a 24-2 or 30-2. Now, this was her CETA swab, wherein the right eye showed a normal CETA swab. The left eye showed a very small nasal spot, which is seen a single spot in the superior arcuate area also. Move ahead with a standard automated perimetry, again was showing a nasal few spots and a superior arcuate spots, scotomas were seen. Now, in this patient, we can, of course, go ahead and do an optical coherence tomography also. I'm just trying to stop here to say what are the tests which are relevant for an early glaucoma. Now, definitely, we have to get a central corneal thickness measurement. So, as per the OHTS and the EGPS study, the average CCT in ocular hypertension was noted to be 570 micrometer. So, the risk of glaucoma was increased when the CCT was less than 555 and compared to 585 micrometer. We should understand the relative risk of developing a primary open angle glaucoma. It increased 81% for every 40 micron thinning of cornea. Another point which I want everybody to understand is, as per the World Glaucoma Association consensus on IOP, the correction factor should not be used to adjust values measured in individual patients. So when we talk about something like we can talk like around 500 as thin corneas, or 570 or 580 or beyond 555 as thicker corneas. Don't try to write +4, +3, +5. That is not relevant anymore to be used as a correction factor. Is there a role of FDT and SWAP? Yes, they are the early psychophysical tests for glaucoma detection. Unfortunately, both SWAP and FDT, they lack defined abnormality criteria like those what we have in standard automated perimetry. So there is a role of doing, you can do in your early cases, a SWAP and followed by a standard automated perimetry. Now, moving on to the second case scenario, this is a 63-year-old lady who had pseudoexfoliation in both the eyes. The IOP was relatively on higher side, 26 and 28, and gonioscopy had open angles. So her one eye showed around 0.7, with little vertically oval cup, whereas the other eye had almost 0.9 cupping with the bipolar thinning, which was seen. Now, when we see her standard automated perimetry of 24-2, her right eye showed a few inferior scotomas and the left eye showed a very advanced glaucoma, which is correlating clinically. Now, this is a 24-2 test which we have used. So, in such situations, when there is an advanced glaucoma, we have to move ahead and do a 10-2 threshold test. Now, if you see the central part, so you can see here there is an early macular split. So the 10-2 threshold test will help us to understand whether there is any kind of early macular split. Suppose we are taking this patient for a surgical intervention or any other intervention, we should understand her central visual field. Now, again, since the central 4 points is showing a split, we can go ahead and ask for a macular program to still further understand her the patient's central vision. So these are the strategies which you should ask for. First, you will go with the 24-2, then move to 10-2, and then if required, you can ask for a macular program as well. So again, to summarize the glaucoma patients, you can ask for a 30-2 or a 24-2 for a newly detecting glaucoma patient. Usually, the commonly used is a CETA thresholding, CETA standard or CETA fast you can use. Now, when we talk about a glaucoma suspect, as I mentioned, you can go ahead with a swab. You can go ahead with 30-2 or 24-2. CETA standard, newer machines have come up with 24-2 central C and CETA faster. And we have to use 10-2 as well. Why is it so? I'll be showing in my subsequent slides. In established glaucomas, you can go ahead, follow-up cases with 24-2 CETA standard. And as I mentioned already, advanced glaucomas, you have to ask for a 10-2 or a macular program. Suppose you have a very elderly or an old patient who may not be able to sit through the test, you can ask for a CETA fast also. Now, why I was mentioning in a glaucoma suspect, we can get a 10-2. So if the patient have any kind of central defects like this, so this is a patient who had a very early notching, which was seen inferiorly. The patient had a central paracentral defect, which is close to the fixation. This is a 24-2. And when we move ahead and did a 10-2, you can see this superior arcuate scotoma, which is very significant, which is seen in 10-2. So Trainees et al. In his study has proven that as much as 16% of the eyes which showed a completely normal 24-2 can show significant abnormalities in 10-2. So whenever we see a central defect, even in early cases, it is indicated to ask for a 10-2 test as well. Now, whenever you ask for a normal, new patient or a newly detected glaucoma, try to get a 2 to 3 baseline reliable fields. If the patients are not able to do, or we've got an abnormal field, it's better to repeat and get a good baseline field, probably before starting the treatment. So that was a summary about how you choose a field test. Now we move on to the other tests like OCT, GDX, HRT. We have umpteen number of machines available. So this is a very old study which was done to understand the diagnostic accuracy of these machines. So it was found that Stratus OCT has a better diagnostic accuracy when compared to GDS and SLP and HRT. Now, this study, why it was significant? Because it was a very large study and it compared the best composite score rather than using only a single parameter. But this is a relatively older study, and if you ask me, economically also most of the organizations will want to buy an OCT since we share it with retina folks also. So this is a patient who came to us, 6/6 vision with one eye pseudophakia and the left eye, other eye had early cataract with the right eye showing a higher intraocular pressure of 24. Now the fundus in the right eye showed a 0.7 with a very early inferior 20. Left eye was relatively normal fundus. So this was a CETA swab study which showed a superior arcuate scotoma in the right eye, whereas in the left eye it was relatively normal, whereas SAP showed a fewer scotomas only in the superior uh, uh, arcuate area. Now, in such patients, it is good to get an optical coherence tomography, which showed a very, good inferior RMNM defect, which was corresponding to our clinical finding of inferior notching. So this definitely tells us that this patient has to be treated because his pressures were also high, 24 millimeter mercury. In the clinical evaluation, you see a notching with an early thinning, which is again diagnosed as an RNFL thinning in your OCT. So in early glaucomas or a mild to moderate glaucoma, OCT does play a good role to help us in your diagnosis. Now, so OCT, if you ask me, it has got a very good reproducibility status, and reliability indices are very good. So always, whenever you are trying to interpret the OCT, understand whether the OCT has a good signal strength. Depending upon what type of machine, it will be written as different measures, and whether there is any presence of artifacts and whether the scan is centered well. All these will help us to understand whether the OCT is reliable. OCTs have progression analysis software which can be used for progression of glaucoma. Definitely, it has a very good diagnostic accuracy. Very interesting factor with OCT is that it has correlated well with patient-centered outcomes. Like RNFL defects correlate worsening quality of life. There have been multiple studies which have done and understood that there has been an excellent correlation with patient-centered, like decreased driving simulation performance, etc. So that way, OCT has a very good utility in these perspectives. Now, the downside of OCT is especially in advanced glaucomas. So as you know, the advanced glaucoma below, when the RNFL thickness becomes below 50 or 60 micrometer, the OCT cannot detect that defect. So in such situations, OCT may not be the right tool for you to ask for. Definitely 10-2 or a macular program is what you have to ask for. And that is how you're going to follow up your patient or treat your patient. So this is something which you need to understand. In advanced glaucomas, OCT may not be the right tool. Now, moving on to follow-up cases. So, do we do a pachymetry in every visit? So, this was a study done by the SN group, wherein they did a study over 3 years. So, they found that a carefully obtained CCT reading by a trained examiner need not be repeated for at least 3 years, as long as the ocular and systemic factors known to affect the measurement are constant. Like, some of the factors which you have to consider is whether the patient has undergone any kind of ocular surgery, any kind of corneal infection patient has had, or if the patient is on say a long-term topical carbonic anhydrase inhibitor that is known to cause a central corneal thickness increase. So in such situations, probably we need not, kind of obtain these pachymetry readings at every visit. But this is like, the choice of the examiner also. If you find that there is any kind of a difference, you can always ask for a repeat CCT. How often do you do the field test? This is always a question. None of the patients really like to do the field test at every visit. So this was a study done in 2017 where they was trying to understand how frequent we should do the field test. So what they have understood is the time to detect a statistically significant negative empty slope, it decreased when we increased the frequency of testing. Okay, but it was not proportionally, but otherwise also it was increasing. So what they mean to say is 80% of the eyes with a mean deviation loss of minus decibels per year would be detected after 3.3 years if they performed once, 2.4 years later if they performed the test twice, and 2 years later if they performed thrice per year. So definitely it's better, more merrier, better, but none of the patients really like to do. So if you ask me practically, if it is mild to moderate, we can ask the patient to perform the test once in a year. But in case you find that there is an uncontrolled intraocular pressure, or there is a finding, extra finding, or there is any evidence of any other changes which is happening, we should ask for a field test. In case of advanced glaucoma, it can be as frequent as 3 months or even 6 months. We can ask for the tests even at 10-2 in cases of advanced glaucomas. So how do we detect progression? Of course, you all know functionally we can detect with visual field testing, and structurally using a swept source OCT or OCT as such, we can help in structural progression. So this is to understand how the reported average rates in glaucoma patients. So in visual field index, it is around minus 1.1 to 1.5 percentage of loss of visual field index can happen per year. This is mainly, we have taken it from the EMGT trial, the rates of visual field loss. Now, if you see, whenever we look for a visual field, we should get minimum of 5 fields. Now here I will tell you one of the practical difficulty is, even if all of us who are participating here has the same Humphrey field analysis machine, we cannot put our report into another person's machine. So these 5 tests have to be done in our own machine. It can only be integrated into your machine software. So they put it into software and we get these two baselines, follow up and followed by the follow-up. So it is very self-explanatory. It's, I mean, if I have to talk about GPA, that itself can be a 1 hour talk. So I'm just telling you that it will be given as possible progression or likely progression. This is how the interpretation happens. So usually it is baseline event analysis as well as a trend analysis. So this is the trend analysis chart, which is seen over the 5 years. What is the trend of this patient's glaucoma progression? So OCT also have event-based and trend-based analysis of the quantitative analysis, which can use the event-based. It says a decrease of 5 micrometer or more in average RNFL thickness, or a decrease of 7 to 8 or more in a sector has to be taken seriously. Again, between the eyes, if there is a difference greater than 9 micrometer, also we should get alerted whether there is any kind of early glaucomatous damage is seen or not. Trend-based is definitely, it is understanding the rate of progression, like Humphrey field analysis over time. It checks the RNFL thickness slope over time. So this is like event-based. If you see this patient's, this is 2017, 20, and followed by 21. So definitely inferior sector, we see a progression which is there from 118 to 95. So there is definitely a significant RNFL defect which is seen in this patient, which is correspondingly seen here also in the map as well. So this is a guided progression software package, which is present. It's a Cirrus HD platform. Different machines will have different platform, which will give us the macular ganglion cell plexiform layer as well as RNFL. So if you see, this is a progressive RNFL thinning, which is seen in a GPA of an Cirrus machine. So it will give us an orange color as possible loss, likely loss, and possible increase. So again, it will be interpreted that way. And this is again both event and a trend over the years. in an OCT analysis. So you can, when a follow-up case comes, you can ask for either OCT progression if it is available, or a visual field progression, and understand whether you need to intervene in any of these patients. Of course, we cannot belittle the role of UBM and ASOCT. So simple thing, this picture shows a cyst which is seen behind the iris. So anything beyond the iris or the ciliary body, UBM helps us to understand, like irises, ciliary body cysts, or any kind of tumors. Probably a UBM is a better machine. And this is an ASOCT picture of the post-trabeculectomy bleb, to understand the bleb wall thickness and the appearance of cystic changes. And this is an ASOCT of tube which is seen here. So definitely these are good tools to have in your armamentarium. In many situations, ASOCT, especially since it's a non-contact procedure, we can get good pictures or good evidences about post PI, Santides Einike, all those things can be seen. So this is just a summary of ASOCT versus UBM, which is usually asked in the exam. So as you all know, these are the quantitative analysis which we can do with both these machines. It's a list of quantitative measurements which we can take with both these machines. Now, talking about some of the newer tools, I'll not say it's newer tools. It's like kind of, it's there in place now. So macular ganglion cell evaluation and optic nerve head marking using BMO MRW. So what is this optic nerve head BMO MRW? So most of these newer OCT machines, they identify the optic nerve head boundary using this Brooks membrane opening, or BMO, as the landmark. So there is something called BMO MRW, that is minimum rim width. So the rim width is quantified, that is the minimum disc between the BMO and the internal rim limiting membrane. That is what is measured currently, and the studies have shown definitely measuring with that. This is the Brooks membrane opening. So definitely measuring with that has given us better results than the conventional measurement. So this is just more like a tool which is incorporated into the newer OCT machine to understand the optic nerve head boundary. Of course, macular ganglion cell analysis, as we know, the more than 50% of the eyes, RGCs, are located in the macula, and GCC definitely helps us to understand the thinning basically of in detection of early glaucomas. So GCC, or that complex, includes the nerve fiber layer, ganglion cell layer, and the inner plexiform layer. So this complex will help us to detect many of the early glaucoma patients. So this is a 3D glaucoma report wherein we can understand the sectoral analysis of these ganglion cells. So this is a recently published study in 2025. So they compared the macular GCC as well as the RNFL in pre-perimetric early and healthy individuals. So what they found is, definitely when compared to the normal or controlled healthy individuals, there was a lowering of RNFL thickness and a ganglion cell layer thickness in pre-perimetric as well as early stage. But within pre-perimetric and the early stage, they could not really find much of a difference in RNFL and ganglion cell layer thickness. So it does help in our early detection of glaucoma. So if you want to summarize it, in pre-perimetric stage, our focus area is on peripapillary and macula. So the metric which we have to analyze is RNFL map and ganglion cell analysis. In established cases, you focus on peripapillary area. So we think of RNFL analysis. For follow-up, you can use a GPA or trend analysis. And in advanced cases, you are going to think about your macula, the central 10-2. So concentrate on macular GCC and of course 10-2 visual fields. That is what will give you more information. Octa, it can only complement in all these examinations. It cannot be a standalone investigation, but definitely there needs to be more and more studies to come up to understand the utility of Octa in detecting the glaucoma. Other investigations being pattern ERG, we can use corneal hysteresis. All these things can be used if you have these gadgets, but these are all complementing to the previously told tools, which are regularly available in most of the clinics or organizations. So, to conclude, it's a disease that requires a clinical diagnosis, definitely advances in functional and structural evaluation techniques. It provides us with more objective documentation and precision for diagnosis and progression detection than just using a subjective method when compared to the past. So, utilize these tools very effectively to understand the progression of this disease. Thank you.
Thank you so much, Meena ma'am. That was a wonderful talk. And I must say, before I thought we were just discussing hydrus and eye stent. We cannot move to gear number 3 if we don't know gear number 1. So it was a
Yeah,
wholesome package. You had the case scenarios and lovely. I loved your talk. Thank you, ma'am.
thank you.
I would like to
Thank you.
welcome Niranjan sir to move ahead with the webinar and give the closing remarks and certificate distribution, sir.
Thank you, Dr. Ritu. Meena ma'am, thank you so much for the most comprehensive coverage of investigations in glaucoma. I think you left no stone unturned, even up to the extent of corneal hysteresis. That was phenomenal. I mean, I didn't really see that coming in glaucoma. So thank you, ma'am. Thank you so much for the most extensive
Thank you.
coverage. And with that, let me quickly move on to the concluding part of our webinar. So at the outset, we are greatly indebted and we are greatly privileged to have Dr. Meena Menon ma'am as a keynote speaker in today's talk. And I think this will serve as a big treasure for all the EOs and TGs who are going in for their exams. So I think this is a complete package of everything put in one place, which will be available in our YouTube archives as well. So for those who missed it, please share it with your friends so that they can benefit from it as well. Then we had Dr. Amrita, who, in spite of her circumstances, came and contributed in a great way by presenting so wonderfully in our webinar. Then we had Dr. Varsha, who immediately agreed to be the monthly mentor and contributed in guiding our presenter for today. Thank you, Dr. Varsha. And then we had the star-studded panel, starting with Dr. Julie Pegu. I think if there was one best way to break down the statistics in this, I think nobody could have done it better than Dr. Julie. Thank you, ma'am. Then Dr. Rita, ma'am. I think the kind of inputs that she gave in a very stepwise manner just was completely it just swept everybody off the floor. And thank you, Rita ma'am, because we really, as yours, we really needed that stepwise approach. And finally, Dr. Arshi, thank you, Arshi ma'am, for being there with us and giving us your valuable inputs. Thank you so much. And our moderator of the day, Dr. Ritu, thank you so much for being the host and being a very wonderful host. And the team which is behind the whole show, Dr. Shreya, uh, Dr. Anujit. So Dr. Anujit has been a part of this initiative since its inception under our immediate past president, Dr. Sonal Kalia ma'am. So thank you, Dr. Anujit, and Dr. Ayushi, and myself, and our journal club lead, Dr. Prasanna. So sir has been the backbone of this whole thing for the last, I would say, 2 years or more. And the moment he took over as a joint sec, he also took over the journal club onto his shoulders, and he's been leading us and been the torchbearer for all of us. So now I would like to place on record my sincere gratitude to Microlabs. And this marks a very important landmark in our collaboration with Microlabs. We have Mr. Kishore, who's the NSM from Microlabs, who's been our main point of contact and coordination. Mr. Kishore, a few words from you on this grand 10th episode of our wonderful journey so far.
Thank you, Dr. Niranjan. See, this gathering is particularly very meaningful for us as it marks 1 year of our continuous association with the YOSI team. I sincerely thank Dr. Prasanna Venkatesh and Dr. Niranjan and the entire YOSI team for this, for allowing us to associate with this wonderful team. Thank you. Thank you all. And
Thank you.
thank Meena ma'am for this accepting our invitation to do a keynote speaker for this CME today. Thank you.
Thank you,
My
Mr.
pleasure.
Kishore.
My pleasure.
So I think it's just the beginning, the first step of many steps going forward. Looking forward to further more collaborations with this wonderful brand. And last but not the least, the governing council for having made this feat possible. In spite of so many big conferences and events happening in close proximity to our journal club, we have managed to pull off a journal club on the first Tuesday of every month for the past record 10 months. So big hats off to the entire governing council, our president, Dr. Devakant sir, secretary, Dr. Nilesh, treasurer, Dr. Aditya, and the entire team for facilitating this. And uh, team Numerotech, I must say, Mrs. Manjula, she's been so prompt and so quick in her response to generating this link for our events and for the smooth conduct. And finally, team from Mahatma Eye Hospital, the designing team, they have come up with the intro PPT and the backdrop for every single event and been a very big pillar of support. And sorry if I missed out on thanking anybody, but really overwhelmed with this journey. And thank you so much, each one of you, for joining us. Manjula ma'am, can we go offline? Yeah, before that,
Yes, before we
I
sign.
think
Yeah.
we'll go offline and then go for the picture. Thank you, everybody.
One second.
Thank you. Thank you all. Good night.
Ma'am, we
Just
just have
a
this
second.
thing of taking a group picture with the YOSI sign. So if
Oh,
you could
Yes,
just join
sir.
us for that.
okay.
I request all of
Sure.
you to kindly switch on your videos. Yes.
Are we still live, Manjula ji?
No, we are offline.
Okay.
Yeah.
Yes. Ma'am, the
Live.
video
Can
sign.
you just click
Yeah,
the
I'll
picture?
take it.
YO. Yeah.
Yeah.
Okay.
Dr. Varsha?
Yeah, I got it.
Yeah.
Dr. Varsha.
Perfect.
No issues. No issues.
Yeah. Cool.
Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Thank you, Kishore sir.
Thank
Thank
you,
you.
everyone.
Thank you,
Thank you
Ritu.
so
Thank you so much.
much.
Shreya, thank you.
Thank
Arshi
you,
ma'am, thank
Ritu,
you.
Thank you,
Anujit,
Ritu. Thank you,
Niranjan, for
Arshi. Thank
having
you, ma'am.
me. Thank you so
Thank you, Arshi.
much, Meena ma'am. I am in absolute awe right now to, actually explain and simplify things. It's so difficult, and you did it. Thank you. I think she's left.
She just left, ma'am.
Yeah, but
It's
it
all
was
right.
amazing, especially for residents, no? It's like,
Yes,
she gave
yes,
like a sankshipt summary of glaucoma diagnosis, and you get that in 30 minutes. It's like, wow, someone
In each
बहुत सारा
diagnostic
ज्ञान
modality with each case,
Yes.
that was so
Yeah,
wonderfully thought.
that was so amazing. I mean, learning
Putting
from
What
the
was
such
interesting,
also,
studies
no,
she was
with
that is how
that.
you
Oh,
she had asked me if
and
she
she
could
gave
finish it
references
off in